Okay, in this last section, I just want to spend some time talking about potassium, and then I want to spend a few minutes looking at renal failure and some of the changes you will see when the kidneys fail. Remember, the kidneys are responsible for many processes, and I want to take a look at what would happen when patients have renal failure. So let's spend a couple of minutes looking at potassium balance and the effects that you will see in a patient with renal failure. So we mentioned the proximal RTA before, but let's summarize. This is a reduced ability of the proximal tubules to reabsorb bicarbonate. Bicarbonate briefly appears in the urine until the filtered load is reduced to match the reduced capacity to reabsorb. At steady state levels, you will see low plasma bicarbonate, high serum chloride with an acidic urine. What can cause a proximal RTA? Fanconi syndrome, which is a defect in the proximal tubule transport process, and carbonic anhydrase inhibitors like acetazolamide. You have loss of sodium bicarbonate in the urine, pulling water with it, creating an osmotic diuresis, resulting in the loss of potassium in the urine, and you see hypokalemia with the proximal RTA. So we spoke about the distal RTA before, but let's summarize. In a distal RTA, the distal tubules have lost the ability to secrete acid. You have lost the ability to excrete fixed acid, and you have lost the ability to acidify the urine. Again, you have lost the ability to excrete acid, and you've lost the ability to acidify the urine. So your urine is not acidic. You have an alkaline urine with a high urine pH. You have, again, impaired renal excretion of protons. These patients will have a hyperchloremic metabolic acidosis. Your serum potassium will be low. Now, these patients will have a positive urine anion gap. If you cannot get acid in the urine, you will have low urine ammonium levels. Remember, most of your acid is excreted in the form of ammonium. So you will have low urine ammonium levels. Therefore, you will have low urine chloride levels. So you will have more sodium and potassium than chloride in the urine. We call this a positive urine anion gap. So you will see a positive urine anion gap in the distal RTA. What can cause a distal RTA? Well, it's autoimmune disorders. Many autoimmune disorders like Sjogren's, SLE, rheumatoid arthritis, several drugs like ifosfamide, amphotericin B, sarcoidosis, lithium, toluene. I actually had a patient with toluene a few weeks ago. So if they give you a teenager who has a distal RTA, think about toluene, because toluene is in glue. So a lot of teenagers, they sniff glue. Why do you sniff glue? To get high. You sniff glue to get a nice high, and then you get distal RTA, and now you have alkaline urine. So glue sniffers, toluene, you can get a distal RTA. So distal RTA, in distal RTAs you could get stone formation. This is for several reasons. In an acidemia, you can get increase in calcium phosphate release from bone. And acidemia can lead to increased bone resorption, and that can lead to increased calcium phosphate release. So now you have an increase in filter load of both calcium and phosphate. Also, we mentioned in the distal RTA, you can have high urine pH. Elevated urine pH favors precipitation of calcium phosphate stones. Remember, calcium oxalate stones will form in an acidic pH, whereas calcium phosphate stones will form an alkaline pH. Calcium oxalate stones will form in an acidic pH, whereas calcium phosphate stones will form in an alkaline pH. An acidemia will also enhance proximal tubule reabsorption of citrate. This is an important concept because citrate inhibits calcium stone formation. Calcium citrate forms a soluble complex, and citrate is a potent inhibitor of calcium stone formation. We actually use citrate to treat recurrent stones. So in an acidemia will enhance proximal tubular reabsorption of citrate, and that will also enhance the formation of calcium phosphate stones in a distal RTA. So this is an important concept to know. Now, a type 4 RTA is the most common RTA. Again, this is due to a hypoaldosterone state. So low aldosterone states will lead to a type 4 renal tubular acidosis. So a hyperkalemic state is due to an inability to secrete potassium. You will get a metabolic acidosis due to a decreased secretion of protons. What are the causes of a hypoaldosterone state? Well, we could commonly see it in diabetic nephropathy. In diabetic nephropathy, you have a low renin state. So this is a hyporenin, hypoaldosteronism. We commonly see it in any drug that inhibits the RAS system. ACE inhibitors, ARBs, spironolactone, eplerenone, aliskiren. Trimethoprim. Trimethoprim can also cause a type 4 RTA, and I've seen this before. And then, of course, there's Addison's disease, in which you have lost the ability to secrete aldosterone from the adrenal gland, and that can lead to a type 4 renal tubular acidosis. So again, you have lost the ability to secrete potassium, leading to hyperkalemia. So in the type 4 RTA, you also will see a low urine ammonium levels, and this is due to transcellular shifts. The hyperkalemia will promote transcellular shifts. It will promote shift of potassium into the proximal tubule cells in exchange for protons. This creates an alkaline pH inside the proximal tubule cells, leading to a decreased production of ammonia. This leads to a decrease in excretion of ammonia. So this is why you'll see low urine ammonium levels in the type 4 RTA. So let's talk about potassium homeostasis. I'm sure you know most of your body's potassium is intracellular. Most of your body's potassium is inside the cell. This is due to the sodium-potassium ATPase, which is actively pumping potassium inside cells. This maintains an electrochemical gradient for potassium. Now, cells have ungated potassium channels, and most cells have a high permeability for potassium. So there is a high cellular permeability for potassium, and there is a larger electrochemical gradient for potassium. And this leads to a high efflux of potassium. So every cell in the body has a high efflux of potassium. Now, when potassium effluxes, it's effluxing trying to get the cell membrane potential to equal its own equilibrium potential. The average cell membrane potential is negative 70. Equilibrium potential for potassium is negative 90. So as potassium effluxes, it is attempting to get that cell membrane potential to equal negative 95. It doesn't equal it because the sodium-potassium ATPase will push that potassium back inside the cell and doesn't allow it to equal that equilibrium potential. So, potassium balance. Excretion of potassium must equal dietary intake. Kidneys regulate potassium excretion. 98% of your body's potassium is found inside cells. Again, this is because of sodium-potassium ATPase. When I say hyperkalemia, I mean the extracellular potassium level is elevated. When I say hypokalemia, I mean the extracellular potassium levels are low. So potassium balance. The exam likes to ask about potassium balance. Let's spend a few minutes on this. Long-term potassium balance is controlled by aldosterone, which is very important. I'm sure you know aldosterone increases renal excretion of potassium in the collecting ducts, and that is responsible for secretion of potassium. So very important to realize that when patients have low aldosterone, or when patients have ineffective kidneys, they're not able to secrete potassium, and this leads to hyperkalemia. So that's an important effect on the long-term balance of potassium. Now, acidosis as well as alkalosis plays a very important role on potassium because of transcellular shifts. You will see when there's an acidosis, there's an increase in extracellular protons which will shift inside the cell, and this leads to a shift of potassium outside the cell. Therefore, an acidosis leads to hyperkalemia. An alkalosis does the opposite. And an alkalosis, that will cause potassium to shift from the extracellular space to the intracellular space, and this will lead to hypokalemia. And this is why we give bicarbonate to treat hyperkalemia, because bicarbonate will induce an alkalosis. That will lead to shifting of potassium from the extracellular space to the intracellular space, and that will very rapidly treat hyperkalemia. Now, metabolic alkalosis has a more potent effect than respiratory alkalosis in affecting serum potassium level. Likewise, when you look at an acidosis, inorganic fixed acid has a more important effect than organic acids, and respiratory acidosis only plays a minor role. So it's really metabolic acid-base disorders that affect your potassium via transcellular shifts. So long-term potassium secretion and excretion is controlled by aldosterone in the kidneys. Hyperkalemia is a direct stimuli for aldosterone secretion from the zona glomerulosa, and aldosterone will increase secretion and excretion of potassium from the principal cells. Now, one important thing to note is in the setting of hyperkalemia, aldosterone is still reabsorbed in the early tubules. So in the proximal tubules, you still reabsorb potassium in the thick ascending loop of Henle, but then you secrete extra potassium here in the collecting ducts under the action of aldosterone. And this is how the kidneys control potassium in high potassium settings. So here's an excellent clinical correlation. Patient has end-stage renal failure. Patient is missing a dialysis session. We see this all the time. When patients miss dialysis, they're not able to excrete potassium because the kidneys excrete potassium. So in renal failure, you develop hyperkalemia because you have lost the ability to excrete potassium. This is life-threatening. So when these patients present to us, how do we treat them? We give them bicarbonate and we give them insulin. Let's talk about how that helps. So we give patients bicarbonate because bicarbonate will create an alkalosis. And we take advantage of transcellular shifts. So if this is a typical cell, when we give bicarbonate, here's a patient with hyperkalemia. By giving bicarbonate, that leads to a decrease in extracellular proton concentration. You're creating an alkalosis here. The decrease in extracellular proton concentration will cause a shift in protons from the intracellular space to the extracellular space. And that will cause a shift of potassium from the extracellular space to the intracellular space in order to maintain electron neutrality. So that will rapidly push potassium inside cells. And that's how we treat hyperkalemia. We give bicarbonate, we create an alkalosis. Insulin helps because insulin activates the sodium-potassium ATPase. Insulin will activate the sodium-potassium ATPase. So that will move potassium into cells. So we also give insulin to activate the sodium-potassium ATPase, and that will also shift potassium into the intracellular space. So this is why we use insulin to treat hyperkalemia. This is why we use bicarbonate to treat hyperkalemia, because they both shift potassium from the extracellular space to the intracellular space. Now, insulin, if you give high insulin levels, it may actually cause hypokalemia, but in this situation, we use it because we want to move potassium into cells. So an acidosis will produce the opposite. In an acidosis, now you have an increase in your extracellular concentration of protons. Protons will shift from the extracellular space to the intracellular space. And in order to maintain electron neutrality, as this happens, potassium will shift from the intracellular space to the extracellular space, promoting hyperkalemia. So now you will see low intracellular concentration of potassium and elevated extracellular concentration of potassium. The classic example the exam will give you here is patients with DKA. In DKA, patients will have a very low intracellular concentration of potassium, and they will have an elevated extracellular concentration of potassium. Now, when you give them insulin, insulin will move potassium back into the cells, so the serum potassium levels will drop very quickly. So part of the management of DKA is to replete potassium, even though when they present to us, they do have hyperkalemia. This is because of transcellular shifts. And as soon as we give insulin, you will activate the sodium-potassium ATPase. You will very quickly push potassium back inside cells, and you will cause hypokalemia. So you're going to have to replete potassium very quickly, very aggressively. This is a high yield point that they like to ask you about on the exam. So promoters of hyperkalemia, as we mentioned, transcellular shifts. That's very important. So metabolic acidosis. As we just mentioned, hyperglycemia, severe insulin deficiency. That's your patient with diabetic ketoacidosis. Insulin deficiency, because insulin activates the sodium-potassium ATPase. In addition, you have an acidosis. You have transcellular shifts. Rhabdomyolysis. When you have rhabdomyolysis and you have lysis of your skeletal muscle, you release potassium. So these are all conditions that can cause hyperkalemia. I want to give you one caveat to this metabolic acidosis, and I'll come back to this later. Remember, the proximal and distal renal tubular acidoses, the proximal and distal RTAs, will actually give you hypokalemia, not hyperkalemia, and that's because of renal losses. Excessive potassium intake is very rare if you have normal kidney. Now, kidneys. Renal failure, whether it's acute, whether it's chronic. Whenever there's a decrease in GFR, you can get hyperkalemia. Low aldosterone states. Aldosterone is necessary for normal renal secretion and excretion of potassium. Aldosterone is necessary for normal secretion and excretion of potassium. So, very important to understand. In order to have normal potassium, you need two things. You need kidneys and you need aldosterone. In order to have normal potassium, you need two things. You need kidneys and you need aldosterone. So, you will see hyperkalemia in two conditions: renal failure and hypoaldosteronism. That's the type 4 renal tubular acidosis. So where there's low aldosterone or where there is renal dysfunction, you will see hyperkalemia. This is very important to know, and you will be tested on this. Clinical effects of hyperkalemia: neuromuscular effects. You can have muscle weakness. Cardiac, you can have peak T waves. Eventually, you can have ventricular fibrillation, and also metabolic acidosis. Hypokalemia is seen in transcellular shifts. We mentioned metabolic alkalosis. We said a sudden increase in insulin because it activates the sodium-potassium ATPase can also cause hypokalemia. GI losses, that's an important one. Diarrhea, vomiting, and low potassium diet can cause hypokalemia. That's an important loss. Renal losses, this is an important one too. Any high flow states in the kidneys can promote renal losses of potassium. This is an important one. That includes thiazide diuretics, loop diuretics, osmotic diuresis of any cause. Now, high aldosterone states. What does aldosterone do? Aldosterone increases renal secretion and excretion. So in high aldosterone states, you will have an increase in renal excretion of potassium. So hyperaldosteronism, whether it's primary or secondary. So if you have an adrenal adenoma, that's primary. Secondary would include something like renal artery stenosis, that is secondary hyperaldosteronism, or patients with cirrhosis or congestive heart failure. Those are all causes of secondary hyperaldosteronism. They could all lead to hypokalemia because of increase in renal excretion of potassium. We also looked at some syndromes earlier today, like Bartter syndrome. Another example of a patient that can get hypokalemia due to secondary hyperaldosteronism. Renal tubular acidosis, type 1 and type 2. Type 1 and type 2 renal tubular acidosis can also lead to hypokalemia. So these are the causes of hypokalemia. Consequences of hypokalemia include muscle weakness, cardiac. You can get hyperpolarization alters excitability, and delays repolarization. So in the cardiac tissue, you can hyperpolarize the cells and delay repolarization. EKGs can show low T waves or T wave inversions and U waves. Metabolic effects, reduce insulin response, lowers growth rate in children, can contribute to nephrogenic diabetes and also metabolic alkalosis. Okay, this is a very important slide in looking at why changes in potassium are so important. Let's take a look at your cell, and let's take a look at why changes in potassium are so important. This is the effect of potassium on this is important, a resting cell membrane potential. Let's say this is a cardiac cell. This is a resting cardiac cell. Now, resting cardiac cells have ungated potassium channels. Ungated means they're always open, means they're open at rest. These channels are always open. And at rest, you always have an efflux of potassium. If you have hyperkalemia, you have an increase in your extracellular potassium concentration. Because of that, you have a decrease in your electrochemical gradient. That leads to a decrease in the efflux of potassium. In fact, if the extracellular potassium concentration is high enough, instead of getting an efflux, you can actually get an influx of potassium. That leads to more positive charges inside the cell. That depolarizes the cell. Now what you can do is you can depolarize a resting cardiac cell. If you depolarize a resting cardiac cell, that can put you into ventricular tachycardia. And that's why hyperkalemia is fatal, because it can depolarize a resting cardiac cell, leading to ventricular tachycardia. Hypokalemia, the opposite. Here's your ungated potassium channel in your resting cardiac cell. Now the extracellular concentration of potassium is low. Now you will increase the electrochemical gradient. You will increase the electrochemical gradient. Now you will increase the efflux of potassium. As you increase the efflux of potassium, you will have less positive charges inside the cell. Now the cell will hyperpolarize. You will push the cell further away from threshold. Now you will fire less action potentials. You may go into asystole. By the way, if this is a resting skeletal muscle cell and you hyperpolarize that skeletal muscle cell, it'll be hard to depolarize that cell. It'll be hard for that cell to reach threshold and fire action potentials, giving you the clinical effect of skeletal muscle weakness. This is why hypokalemia will lead to skeletal muscle weakness, because it is hard to reach threshold, because hypokalemia will hyperpolarize your resting skeletal muscle cells, and it's harder to reach threshold and fire action potentials. So now I want to spend a little bit of time going over acute renal failure. Acute renal failure means that there is a rapid loss of renal function that may be reversible. This is due to a rapid decrease in the GFR. This leads to an accumulation of waste products such as BUN as well as creatinine that are usually excreted by the kidney. When you see acute renal failure, you have to consider, is this pre-renal, post-renal, or intrinsic renal? If it's intrinsic renal, it could be allergic interstitial nephritis, it could be acute tubular necrosis, or it could be glomerular nephritis. If it's glomerular nephritis, you have to consider, is this the nephritic syndrome, which is due to inflammation of the glomeruli, or is this the nephrotic syndrome, which is due to loss of the glomerular basement membrane? And I will take a look at how you can tell the difference between pre-renal, post-renal, or intrinsic renal. The FeNA stands for fractional excretion of sodium. This is very helpful in helping you differentiate between the causes of acute renal failure. The FeNA refers to the percentage of filtered sodium that is excreted in the urine. The higher the FeNA, the less sodium that is reabsorbed, meaning the less that is reabsorbed, the more that is excreted. So the higher the fractional excretion of sodium, the more that is excreted. Basically means it's not being reabsorbed. If the FeNA is low, low FeNA means that it is being reabsorbed, it's not being excreted. So the FeNA could be elevated or reduced. depending on the case. Now again, the cause of acute renal failure could be pre-renal, intrinsic, or post-renal. The FENA will help tell you the difference. In pre-renal azotemia, the problem is due to a decrease in renal perfusion due to a hypovolemic state. This could be due to hemorrhaging, diarrhea, vomiting, or congestive heart failure. There is no intrinsic renal injury at the initial stages of pre-renal azotemia, and this is reversible if caught and treated early. How do we know we're dealing with pre-renal azotemia? Well, there will be a reduced GFR due to decreased renal perfusion and decreased renal blood flow from the low volume state. In these patients, you will see a reduced FENA, less than 1%. The FENA in pre-renal azotemia must be less than 1%. That's the definition. The tubular function is still intact. The low GFR will allow for significant reabsorption. We mentioned this in the beginning. We said in a low volume state, there will be an increase in reabsorption. If the tubules are still intact, they will be doing their job in a low volume state, which is what? Increased reabsorption of sodium to replace the volume that is lost. So you will see a low excretion rate of sodium here. You will have an increase in reabsorption of sodium because of what? Angiotensin II and aldosterone will be elevated in these patients. Another helpful sign here is the BUN to creatinine ratio. These patients will have an elevated BUN to creatinine ratio. Why? Because low volume states will lead to an increase in ADH secretion. And ADH will lead to an increased reabsorption of urea. And that will lead to elevated BUN. So the BUN will be higher than the creatinine in a pre-renal azotemia. So these are two very helpful signs in telling me that this is a pre-renal azotemia. Now, in intrinsic renal failure, there is tubular damage leading to tubular dysfunction. This could commonly be due to ischemic acute tubular necrosis. This is due to necrosis of the tubules, most commonly due to hypotension. I commonly see it in sepsis in my patients. This could be due to congestive heart failure or hemorrhage. The tubules get ischemic damage from decreased flow rates. This could be due to drugs that inhibit autoregulation. NSAIDs, common culprit. COX-2 inhibitors or ACE inhibitors or ARBs. You will see muddy brown cast. Now, this is a high yield point. The proximal tubules and the thick ascending limb of the loop of Henle are most prone to ischemic acute tubular necrosis because these are two parts of the nephron that are highly metabolic, that use a lot of ATP. They're very metabolically active, so they're very prone to ischemic damage. So these are the two portions of the nephron that are prone to acute tubular necrosis. Now, most patients recover. They may need dialysis, but most recover. Now, here's a high yield point. As patients recover, now at some point during acute tubular necrosis, patients will become oliguric. They most likely will need dialysis. But as they recover, they start to make urine. The oliguria will recover. They start to produce urine again. As they start to produce urine, they have a diuresis. They get a very rapid diuresis, and they increase the urine flow rate. As they increase the urine flow rate, they get an osmotic diuresis. And that increase in flow will lead to renal losses of potassium. So during recovery, you have an increase in urinary flow rate, and you can have renal losses of potassium. So you have to monitor all their electrolytes very closely. As they're recovering, they're at high risk of hypokalemia during that acute recovery phase. So as they're recovering from acute tubular necrosis, watch out for hypokalemia. And that's a particularly high yield point that the examiners like to go after. So what are signs of intrinsic renal failure? Well, these patients have damage of the tubule cells. So in this case, the epithelial cells of the tubules are damaged. And as they get damaged, they sloughed off and they physically clog the tubule. And as they clog the tubules, you have a drop in GFR. And you have lost the ability to filter. You've lost the ability to filter, so you see a rapid drop in GFR. You also have lost the ability to reabsorb sodium. You've lost all of your renal function, so you have a drop in GFR, you have a drop in the ability to reabsorb sodium, so now you have an increase in the FeNA. So you have a high FeNA here. Increase in the excretion rate of sodium. You're wasting sodium. You get sodium wasting and intrinsic renal failure. You could see cast in the cells. You actually see the sloughing off of the cells in the urine. Now, your BN to creatinine ratio will be low here because, again, you're going to have a rapid drop in your GFR. This situation, you've lost your GFR, so now you're going to see a rapid increase in your creatinine because you simply cannot filter creatinine now because your GFR has dropped. So creatinine will rise up. Nephrotoxic ATN, there are many drugs that can cause nephrotoxic ATN, such as sulfa drugs, acyclovir, and dinavir. The examiners love to go after aminoglycosides, very commonly tested, amphotericin B, cyclosporin, tacrolimus, cisplatin, that's a big one, radiographic contrast dye, myoglobin in patients that have rhabdomyolysis, ethylene glycol, the oxalate crystals, and then uric acid in patients with tumor lysis. So these are all causes of acute tubular necrosis that can be directly toxic to the tubules. So you should avoid these in patients that have acute tubular necrosis. This is a biopsy looking at acute tubular necrosis. And you can see there's your glomeruli. Your glomeruli are not affected here. But if you look at the tubules right here, you can see the tubules are clogged with necrotic tissue. So you can see here the tubules are clogged with necrotic tissue. And here's some normal tubules. You can see some normal tubules here that have a normal lumen. Okay, these are some tissues that actually have a normal lumen. But up here, it's very hard to see normal lumen up here. So all these lumen are physically clogged with necrotic tissue. So this is a biopsy of acute tubular necrosis. So another cause of intrinsic renal failure is allergic interstitial nephritis. This could be caused by certain drugs such as penicillins, NSAIDs can cause this, cephalosporins. Patients with allergic interstitial nephritis present with oliguria, acute renal failure, with a rash and a fever. And classically, they will have eosinophils in the urine. Now, they usually recover when you stop the offending agent. On biopsy, you will see inflammatory cells in the interstitium. This is a disease of the interstitium. Usually, the tubules on biopsy will not be affected. So if you look on biopsy, the tubules will be unaffected, but you will see inflammatory cells in the interstitium of the biopsy, and they will recover when you stop the offending agent. So post-renal azotemia is caused by obstruction of outflow from the kidney, usually due to renal calculi or an enlarged prostate. Now, in early stages, the findings are exactly the same as pre-renal azotemia. You will have a low FeNA, and you will have an increase in the BUN to creatinine ratio. This is because imagine the ultrafiltrate just sitting there. You will increase reabsorption of urea, so the BUN will go up. Now, the epithelial cells will still be intact, so you will still be able to function. You'll still be able to reabsorb sodium, so you will not have a change in your fractional excretion of sodium. So your FeNA will still be low. Now, in the late stages, the high pressures, the increased pressures will actually lead to tubular damage. So you will get loss of epithelial cells, and then you'll have characteristics of intrinsic renal failure, meaning the FeNA will increase, and you will actually have a low BUN to creatinine ratio. And that is post-renal azotemia. Now, chronic renal failure. In acute renal failure, the nephrons may recover. In chronic renal failure, there is irreversible loss of the nephrons. Now, the remaining nephrons will compensate by increasing glomerular capillary pressures. This leads to a concept known as hyperfiltration. This creates glomerular hypertension. This glomerular hypertension leads to increased workload on the remaining glomeruli, leading to fibrosis, scarring, and further loss of the nephron. This is why we use ACE inhibitors in some patients with chronic renal insufficiency. Any patients with the nephrotic range proteinuria, we use ACE inhibitors to treat the glomerular hypertension, to reduce the hyperfiltration, and to reduce the time until patients go on dialysis. So consequences of chronic renal insufficiency. You have a rise in BUN and creatinine due to inability to excrete these waste products. You will have uremia. Uremia is a clinical syndrome that consists of nausea and vomiting, lethargy, confusion. Patients may sometimes go in a coma, asterixis, also known as a flap. They may develop pericarditis, and they may get platelet dysfunction. And due to the platelet dysfunction, they may have bleeding. So if patients come in with emergent bleeding, we can treat them with desmopressin. Desmopressin will lead to an increase in release of von Willebrand's factor from endothelial cells, and that will increase platelet aggregation, and that will stop the bleeding in patients with platelet dysfunction. So that's an important fact to know. These patients will also get sodium and water retention. Remember, one of the functions of the kidneys is to control volume status. These patients will get volume overload, leading to edema. Electrolytes. The kidneys excrete potassium. So in chronic renal insufficiency, you lose the ability to excrete potassium, and you may see hyperkalemia. Acidosis. You will see an anion gap metabolic acidosis. This is due to loss of the ability to excrete fixed acids. Remember, acids are excreted in two forms: titratable acid, which is phosphate, and ammonium. So there's actually two reasons to develop an acidosis here. One is you've lost the ability to filter phosphate. Remember, where does phosphate come from? We eat it, our diet. So when your GFR decreases, you have reduced the filtration of phosphate. If you're not filtering phosphate, you've just lost your buffer. So that's loss of your buffer. That's one reason why you develop an acidosis. You've lost your buffer, so you have lost the ability to excrete acids. Another reason is loss of the ability to synthesize ammonia. Remember, the proximal tubule cells synthesize ammonia. That ammonia is very important in buffering acids. So in renal failure, the proximal tubule cells have lost the ability to synthesize ammonia, and you cannot form ammonium, and that leads to an acidosis. Again, in renal failure, you have lost the ability to excrete fixed acids, and that's why you develop an acidosis. Now, here's another common effect that the examiners like to go after. Low phosphate excretion leads to hyperphosphatemia. Hyperphosphatemia binds to calcium, leading to low calcium levels. This causes a rise in PTH. This is known as secondary hyperparathyroidism. This chronically elevated PTH will lead to increased bone resorption, leading to renal osteodystrophy. Another effect you will see is the inability to hydroxylate 25-hydroxyvitamin D. Remember, the proximal tubules possess alpha-1 hydroxylase. Alpha-1 hydroxylase is activated by PTH, and that hydroxylates 25-hydroxyvitamin D to form activated vitamin D. In renal failure, you cannot activate vitamin D, leading to low levels of activated vitamin D, and that contributes to hypocalcemia. Anemia. You will also see anemia in chronic renal failure due to inability to secrete erythropoietin. Now, the most common cause of chronic renal failure is by far and away diabetes. This is the most common cause of chronic renal failure. So I just wanted to take a minute to summarize pathophysiology of renal osteodystrophy, because this is a high-yield topic that the examiners like to go after. So let's spend a minute on this. The decrease in GFR will lead to hyperphosphatemia. phosphate binds calcium. So the high phosphate will bind to calcium, leading to a low serum calcium levels. The hypocalcemia will lead to high PTH secretion. This is secondary hyperparathyroidism. The chronically elevated levels of PTH will increase bone resorption, leading to what we call osteitis fibrosis cystica. This is the concept of renal osteodystrophy. In addition to this, the decrease in GFR, and also most patients have low 25-hydroxyvitamin D anyway. This is vitamin D deficiency. Everybody has low vitamin D levels, so most patients have vitamin D deficiency. So that combination will lead to low activated vitamin D. So these patients will have low activated vitamin D, low 125 dihydroxyvitamin D, and that will contribute to the hypocalcemia. So this is the pathophysiology of renal osteodystrophy. So this is very important to understand this. The examiners like to go after this. This is very commonly tested. So make sure you understand this pathophysiology. You will see this on the exam. Now, how do we treat this? We have to go after the phosphate, right? The phosphate's the problem. So we give phosphate binders. We give them calcium, Levemir. These are some drugs that bind to phosphate in the intestines and reduce the phosphate levels. So that's how we treat these patients. Now, what is osteitis fibrosis cystica? This is subperiosteal resorption, and this is another concept they like to ask you about. High PTH levels, chronically elevated PTH levels, will lead to subperiosteal bone resorption. That's what osteitis fibrosis cystica is. It is subperiosteal bone resorption. You could see it on the x-rays here. On the x-ray here, you see subperiosteal bone resorption. And then this bone is replaced with fibrosis. And this is what we call Brown's tumors. So you could see Brown's tumors on the x-ray here. And this is what Brown's tumors looks like. This is due to chronically elevated PTH levels, leading to subperiosteal bone resorption. And this is osteitis fibrosis cystica. You can also see this in patients with primary hyperparathyroidism. Same idea, chronically elevated levels of PTH. You also can see this with vitamin D deficiency. Vitamin D deficiency will also lead to secondary hyperparathyroidism, chronically elevated levels of PTH, and then they can also develop osteomalacia or rickets in children. So that is the end of the renal physiology section. I hope you enjoyed this. I hope you found this very helpful. I hope you now love the kidneys. I hope you dream of the kidneys. I hope you take good care of your kidneys. And more importantly, I hope you finally understand the kidneys, at least well enough for step 1. And maybe I may have turned some of you into nephrologists. Maybe you hate the kidneys, but at least I hope you understand them for step 1. It was my pleasure to help you in your endeavor to become physicians. Take care, and good luck.